Sawadee krab, everyone. Good afternoon from Bangkok, Thailand. My name is Midnight. I am the Executive Director of APCOM, and we're so very grateful for you to join us on a Monday from wherever you are. Thank you for tuning in on this discussion around the increasing access to antiretroviral therapy for key populations in the Asia-Pacific region. So this webinar is in partnership with the PEPFAR USAID EPIC, a regional webinar to ensuring that we are learning about increasing access to ART for key populations in our region, and to learn about the latest information on ART and to strategize with the community-led advocacy organizations and actions to increase access to quality ART in our region. So the objective for this meeting is really threefold: to share latest information on ART, to discuss barriers to accessing quality ART for key populations, and lastly, to strategize on community-led advocacy for the increase of ART, quality ART in our region as well. This webinar will be about 90 minutes, so quite a short time, but we're looking to pack this session full of information. Oh, thank you, team. So now we just going through the housekeeping for this session. So as you can read here, might be a long list, but you'll probably be very familiar with it by now, since we've been 3 years in the COVID-19 doing Zoom webinars. First of all, please do rename yourself and share your details, have your name, organization, and country where you're based. This session will be recorded to ensure that those are not able to join us today will be able to then access this information, and it will be posted on our website and social media. Please do keep your microphone on mute at all times unless you are speaking. We will have a bit of time for question and answers, but you may use your chat function to type in your questions, and our speakers have been informed that they can also reply to your questions in the chat function as well. So in the formal Q&A session, just please raise your hands, and then I'll be able to ask you to unmute yourself, and then you can ask your question. We also appreciate that you can use all the functions within the Zooms, including applause and appreciation, reactions, sending loves and thumbs up. Feel free to use that. A lot of the questions that we get asked is about will the presentations be shared after the webinars. Yes, they will be, along with a short survey with a post-engagement survey to ensure better webinar experience for you in the future. We will also include the write-ups and summaries on our newsletter. If you haven't signed up to our newsletter, please do go onto our website, apcom.org, and then sign up at the bottom of the website page. If you want to tweet or take a screenshot in today's session, please ask permission of contributors before quoting them or sharing the screenshot of them, whether they are speakers or participants contributing throughout the chat and Q&A function. So please remember to do that. And also a reminder, very important, to be respectful in every aspect of the speakers and participants sharing and contributing their ideas and experiences here. This webinar is a safe space where people from diverse backgrounds come together to learn, to appreciate, accept, and as well as celebrate differences and find solutions for continued discussions. Thank you so much, team. And I think without further ado, I'd just like to maybe go through the agenda just briefly. We'll have some welcoming remarks from the Asia Network of People Living with HIV, and we'll also have a presentation from WHO Southeast Asia Regional Office on WHO guidelines about ART recommendations, and then we'll get a bit of time to do a Q&A. And then we'll go to the Pacific. UNAIDS Pacific will be talking about ART access gaps, a region that we don't normally get to hear about. And then you will get a bit of Q&A there as well. And then we'll have discussions from country examples from the Philippines and from Thailand, and there'll be a bit of Q&A afterwards. And lastly, we'll end with the role of community-led monitoring in improving the quality of ART access by USAID EPIC Thailand. So that's how the 90 minutes will be split. So as I mentioned earlier, please do use the chat function and introduce yourself, and feel free to use that as a networking area as well. I hope that's all good. And without further ado, I would like to then invite our first speaker, Davi, who is young PLHIV from the Asia Pacific Network of People in HIV. Davi, over to you.
Yeah, thank you, Kun Midnight, for the introductions, and good morning, everyone. Once again, I'm Davi as a young PLHIV officer of EPN Plus. EPN Plus is a regional network led and working for people living with HIV in Asia and Pacific. My capacity today maybe covers how our work, as well as me as a person living with HIV and on treatment for more than 10 years. As we know that the issues of access to treatment is a fundamental component of the full realizations of the right to health. Currently, treatment is not only about curing the disease, but in the perspective of key populations and people with HIV, treatment is also important as an effort to prevent and control. Personally, the first time I accessed ERV was because when I was a teenager and joined a peer support group with Intermedica Foundation in Jakarta. At that time, I saw a few of my peers who were afraid of taking medication and stopped taking medication for several reasons. Then this make them sick and eventually die. This really broke my heart, and makes me want to be a treatment role model for them who just found out about their HIV status. I carry out various campaigns on my social media and got a lot of response from them. I also wrote a book about 20 stories of young gay men who living with HIV in Jakarta. And with Inti Muda Indonesia, we are also create a shelter or safe house, which intended for young people with HIV who experience stigma and discrimination because of their HIV status. And for the first time, flashback, I also took part in the Jakarta Marathon event. I was running for 21 kilometers while conducting campaign and being open in the public as a person living with HIV. With only one message that even though I'm HIV positive, I can do anything like everyone else. That sound. Okay. Yeah, in addition, APN Plus also recognize that the education related to treatment literacy is still very limited in almost every in Asia. Thank you. And left behind in other knowledge. As a result, most people with HIV are lack of understanding about the importance of early treatment, adherence, and how ERV work to improve the quality of life. Aside from stigma and dissemination, PLHIV also often experience concerns about ERV stock out. For example, because currently I'm living in Indonesia, when we are facing crisis due to COVID-19 pandemic, we also had to face more difficult condition due to the stock out of antiretroviral for several weeks. And recently, it's also happened in Sri Lanka. Healthcare providers in Sri Lanka have also found a shortage of vital medications for newborn children living with HIV. Then they are asked family who need ERV for their children to find the ERV by themselves. Thankfully, with the working of APN Plus to our network at the country level, the problem was resolved temporarily. Thanks to our partner who helped in India. Again, this is temporary, so we need to monitoring the situation together to ensure the treatment for everyone in Sri Lanka. In the near future, APN Plus also plan to conduct workshop related to target drugs. This aims to provide update on the latest clinical intelligence, market, and patent on HIV, hepatitis C, tuberculosis, and opportunistic infection. On people needs, current clinical recommendation, pricing, production, and etc. and others. and to discuss in depth the current and future priorities of target medical product in the Asia and Pacific context. It may not sound familiar to someone like me who come from the grassroots, but yeah, we have to learn something new. And yeah, for the last, it is the task of EPN Plus and all regional networks such as APCOM and others who are part of the 7 Alliance Consortium and other stakeholders, of course, to continue to work and to ensure the treatment for all. I believe that without meaningful support and participation from all of you, improved access to treatment can't be possible. And hopefully, through today's webinar, we can formulate new strategies going forward to improve access of key population and PLHIV to accessible and affordable treatment. Once again, thanks to Kun Midnight, to APCOM for this opportunity. Hopefully, today's webinar goes well and fun. Over to you, Kun Midnight. Thank you.
Thank you so much, Davi. Can we please get a round of applause for Davi, and also thank you for the partnership with APN Plus on this webinar as well. It's really encouraging to see a young person in HIV from the grassroots, like you mentioned, Davi, and sharing that story is really powerful. And thank you for sharing that with us today and being with us for the webinars as well. It's really encouraging to see younger leaderships in the region coming up. So we applaud you for the work that you're doing in terms of ensuring that you mentioned about stockouts in Indonesia, in Sri Lanka, and then and also in monitoring that in our region as well. So looking forward to working more with you in the future to ensure that this advocacy really ensures that people in the grassroots can get the best access to ART as possible. All right, and now we can go on to the WHO guidelines. What does it say about ART recommendations and implementation? So we're very lucky to have Dr. Rawari, who is the regional advisor on hepatitis, HIV, and STIs based in New Delhi at the WHO Southeast Asia Regional Office. Dr. Rawari, thank you so much for giving us your time to be with us this afternoon.
Good morning and good afternoon, everyone. I would like to thank Midnight specifically, but APCOM in general for giving me this opportunity for this important webinar that you are having. And it was very nice listening to Davi basically on his perspectives from young PLHIV population and the challenges that are faced. I hope you can hear me clearly.
Yes, we can hear you.
Okay. So I'm quite happy that this webinar has been designed basically on ART, increasing access to ART for key populations, because we know that we have 3.7 million people living with HIV estimated in Southeast Asia region, and out of that 25% still do not know their status. But it is not uniform across all populations. The people knowing their status is different among different typologies, different regions, and different countries. And though on 95, 95, 95, we are at 75, 61, 58, but we all know that the disaggregated data for different key populations is not available fully in most countries, and access to key populations remains limited. So this webinar offers an opportunity to discuss the barriers and how can we move ahead further. So the learning objectives of this are basically, I would like to familiarize participants with basics of ART, but most of you are aware of them, being in HIV area for quite some time, but I would just like to give it very briefly and then move on to differentiated approaches for key population, PLHIV, what are the WHO guidelines. In addition, I would also like to add a little bit on prison inmates, migrants, and mobile populations, and then what are the future options for antiretroviral therapy. So quickly, we know that antiretroviral drugs, these are the drugs which act at different stages of the viral replication. These are the classes of drugs, not going into details at all, because these are well known to people, participants. We also know that the guidelines have been changing over the years, and now for many years, the guidelines are to treat everyone who is diagnosed with HIV infection regardless of CD4 count, WHO clinical staging, any age and any population. We also know that recently there has been a shift to most countries in dolutegravir-based regimen, and the evidence came from almost 3,000 experience from 3,000 patients who were treatment naive and treatment experienced. And these were the studies, single study, Flamingo, Spring study, and Sailing studies, which basically provided us few key points which were known, but I would like to reiterate these, that with dolutegravir compared to efavirenz, the viral suppression is rapid, just in 4 weeks compared to 12 weeks with efavirenz. Very important point in preventing transmission. The toxicities are fewer. That leads to minimal discontinuation, less than 2% compared to efavirenz. Though there are neuropsychiatric events, but they are significantly more common with efavirenz. Just that insomnia was reported more frequently in dolutegravir-based regimen. But it is important to again re-emphasize that there are no known treatment emergent resistance across different trials for dolutegravir. There are minimal drug-drug interaction, except that with the rifampicin, the dosage has to be adjusted to twice daily. Very high genetic barrier to resistance, effective against HIV-2 also, and now with availability of pediatric formulation, harmonization across patient populations is possible, and also with the reduction in the incidence of the neural tube defects, this can be utilized across all populations. So in 2019, WHO updated the guidelines, bringing in TDF-3TC, DTG as preferred regimen, and this was changed from a conditional to a strong recommendation in 2019. In situation where you can't use dolutegravir, efavirenz was the alternative first regimen, and in the doses of 400 milligram, not 600 milligram. In special circumstances, you can use other preparations, but the preferred regimen remains tenofovir, lamivudine, or efavirenz combined with dolutegravir. And this is the summary of 2019 WHO guideline on the first-line regimen. Dolutegravir was brought in for the children also, and also for the neonates where dolutegravir cannot be used. Dolutegravir is recommended as the preferred regimen. Dolutegravir has also been brought in as a preferred regimen in situations where people were on efavirenz-based first-line regimen and they failed. Dolutegravir along with AZT3DC was recommended as the preferred regimen. And for those who are already on dolutegravir-based regimen, first regimen, it was atazanavir, ritonavir as the preferred second line. And the evidence has shown that dolutegravir has better outcomes compared to any PI-based regimen for patient failing on efavirenz-based regimen. There were a lot of concerns initially with the neural tube defect issues and dolutegravir safety risk for women with childbearing potential, but it is thought to be much less than the originally signaled. And if you see, this has been changing over the time, and the updated prevalence in the study, CPEMO study, has shown that the prevalence has declined from initially 0.94%, which was 4 out of 426 exposure, to 0.3%. So the difference remains statistically significant, but overall risk remains very low. And given the choice to the pregnant woman, to the woman of childbearing potential, not the pregnant woman, women who are already pregnant, the neural tube has already closed, so there is no issue on that. Coming to quickly to some of the side effects, we know the side effects of dolutegravir: insomnia, headache, dizziness, tiredness, very few allergic reactions, but DTG-associated weight gain has been an issue now. And WHO recommends that we need to highlight the importance of a healthy diet and regular exercise to help manage the weight gain associated with dolutegravir. These are some of the studies, advanced studies, NAMCEL and CPEMO studies, where treatment with dolutegravir was associated with weight gain. And this was found to be more pronounced when dolutegravir was combined with TAF compared to TDF. And in the arm of TAF, the weight was 6 to 8 kgs compared to 3 to 5 kgs in TDF, FTCD, or dolutegravir-based regimen. So these are some of the studies which basically earlier response for community was that weight gain is viewed as a favorable outcome, but now with more and more people on dolutegravir, the weight gain could be a problem. So adequate counseling on healthy diet, avoidance of tobacco, exercise, other factors which are important for cardiovascular diseases need to be emphasized. Coming to a word of caution, We know that dolutegravir has got some drug-to-drug interaction which are very minimal, but the two important drugs are basically rifampicin, where we have to use dolutegravir twice daily, or substitute with rifabutin, and we know rifabutin is not available easily. So dolutegravir has to be used twice daily. So in addition to one tablet of TLD or the tenofovir, lamivudine, dolutegravir, we need to add one tablet of dolutegravir 12 hours apart, 50 milligram. Another important interaction is metformin, because we know that in many countries like India, 8% of the population has got diabetes. So we have to limit the dose of metformin to 1 gram per day when used with dolutegravir and monitor glycemic control adequately. Another important drug interaction, which is with very over-the-counter drugs, basically, which are antacids, multivitamins, supplements which contain aluminum, calcium, iron, magnesium, zinc. We have to use 2 hours before these drugs or 6 after DTG. So a lot of emphasis has to be laid on these 3 points when we are doing counseling, peer counseling, or counseling at the antiretroviral sites. Some of the drug interactions are amiodarone, carbamazepine, phenytoin, but the 3 important ones remains these. When we talk of key population, it is important to note that dolutegravir has no effect on the pharmacokinetics of methadone or buprenorphine, can be safely used in same dosage with these drugs. It also does not have any interaction with oral contraceptive, which has got norgestimate or ethinyl estradiol. So people on hormonal replacement therapy, on OST, can take dolutegravir safely without any fear of change in the dosage required. Rifampicin I've already mentioned, metformin I've also mentioned. But there would be some people still on efavirenz-based regimen who cannot use dolutegravir for any reason. We have to remember that when used with methadone, it decreases methadone Cmax by 50%. So patients should be monitored for signs of withdrawal. These are specifically important in terms of key populations. We all know this. Just to re-emphasize again that when we talk of treat all, same-day initiation, rapid ART initiation, patients should be adequately prepared and counseled, and their caregiver should also be counseled adequately. Very important that treatment should not be enforced on the patient when going for same-day initiation. We know the benefits of same-day initiation, but we should also understand that treatment should be started based on person's informed decision and preparedness after identifying a caregiver, and also disclosure of the status, and ensure access to adequate nutritional and emotional support needs of the PLHIV. We know that antiretroviral therapy is now being positioned and should be promoted basically in terms of evidence from HPAT and O252, PMTCT, and other studies, that we need to emphasize U equal to U whenever we talk about antiretroviral therapy. We also need to promote antiretroviral therapy for prevention, pre-exposure prophylaxis. I know the uptake in Thailand has been better than other countries, but still, if we see across Southeast Asia, just 40,000 people receive PrEP, which is an important tool for prevention, and we are not adequately utilizing this. Though Thailand has been leading this, but still whatever is there is inadequate, and we really need to focus on the PrEP. Just closing the ART guidelines, I will just like to emphasize what is in your future, and there are 2 prominent trends, basically fewer drugs. Can we go to dual drugs for new patient, or dual drugs for patient who are already stable on 3-drug regimen, and what are the long-acting formulations? So very briefly, there are 2 studies, Gemini 1 and Gemini 2, basically, which shows that dolutegravir 3TC is non-inferior to dolutegravir tenofovir 3TC in treatment-naive patient who have not received, and their evidence has been there for a long-term durability of 2-drug regimen. No difference in terms of outcome by age, sex, race, baseline viral load count, but this is still to come into the guideline. Then there is a Tango study which says that even people who are stable on a 3-drug regimen, if they are switched to 2-drug regimen, even at week 96, it was not inferior. And then I think most people know about cabotegravir, Atlas 2M studies where cabotegravir, rilpivirine, long-acting, given 8 weeks, continues to be non-inferior to administration every 4 weeks. We know about the use of cabotegravir has been approved for PrEP also. So these are some of the emerging trends in antiretroviral therapy. Now I would like to move a gear on the webinar for this day, talking about the special population, the key populations, vulnerable groups, positive pregnant women, children, adolescent, but my emphasis will be basically on key population today out of this group. And this must be known to all of you, the differentiated antiretroviral therapy approaches which WHO came in 2017, where we need to basically discuss on the when, where, who, and what of the differentiated service approaches. And most countries in the region have adopted these guideline differentiated service approaches, and particularly during COVID-19, the multi-month dispensing was taken up by most countries. We have evidence from many countries on the community distribution of drugs, particularly the nice work that was done by the communities, even on the home distribution of the drugs, community refill groups that will form, community education, and the webinars that were held. So there has been focus on differentiated service delivery group, but what came in WHO policy brief basically in 2022, these were the consolidated guidelines on HIV, viral hepatitis, and STI, prevention, diagnosis, treatment, and care for key population in 2022. I hope you have access to these guidelines already, but the 6 key recommendations that came from these guidelines, I would like to emphasize, and these are all based on the great recommendation. So these guidelines recommend that online delivery of these services to key populations may be offered as additional options, but while ensuring data security and confidentiality. And this is a choice. Online services should be part of menu of intervention and not standalone intervention. The second recommendation is that peer navigators are recommended to support people from key population to start the treatment and remain in care. Previously, these were more focused on remaining, retention in care, or provision of the refills, but now they are recommended to support people even on treatment. And basically, these also emphasize that peer navigators should be required adequate enumeration. They should have recognition and training and other supports to fulfill their role. And this also comes as a part of our guideline of our integrated regional action plan for 2022 to 2026 from CRO, that community health workers should be taken at par with the government health workers, that parity should be brought in. We know that peer navigators are highly valued by their people. Another recommendation was that people on ongoing risk and history of treatment-induced or spontaneous clearance of HCV infection should be offered 3 to 6 monthly testing for the presence of HCV viremia, just to see basically for any chance of reinfection. And those who are infected should be offered without delay to directly access to pan-genotypic direct-acting antiviral drugs for HCV. So these are some of the key recommendations. And lastly, basically, the recommendation is a good practice statement that addressing chemsex, especially for key population and their partners, requires a non-judgmental approach, which should be a person-centered care and include integrated sexual reproductive health, mental health, access to steroid needles, and OST services with linkage to other prevention, diagnostic, treatment interventions. It is very important that the definition of chemsex varies slightly within the drugs, and it has been defined that it is defined as when individuals engage in sexual activity while taking stimulant drugs, typically involving multiple participants over a prolonged time. So based on these recommendations, some of the differentiated care guidelines which have been adopted in India and which can apply to any country, these are very generic, basically include that peer navigation should be encouraged, but people who are diagnosed, key population, should basically have a accompanied referral to the treatment site. If it is not at the facility within the network or within the NGO, it should be accompanied referral, and the ART counselor should be adequately trained to build rapport with the key population and also collect their contact details of NGO from this person was referred, so that we have a proper follow-up. In terms of ART initiation, it varies differently, but we should keep in mind that KP, PLHIV have got different lifestyle, they have different timings. Repeat visit to the site may be difficult for them, and chances of being lost to follow-up are significantly high. So counselor at the referring network, including the ART center, it may be NGO or whatever network it is, a PLHIV network, they should provide adequate preparedness, adherence counseling to fast-track initiation. Same-day ART initiation should be encouraged as far as possible, but definitely we have to provide services customized to their needs. We have to identify what are the life challenges which may impact the adherence, so we have to have individualized solutions. And we have also to see what are the barriers that may face adherence. Sorry. So we have also to emphasize on the message of U equal to U, including partner testing, index testing, and ensuring differentiated care models. Lastly, in tracking people who are lost to follow-up, particularly key population, we have to work together with the ART center, with the outreach workers, with the networks, depending on the country context and the settings, that these people who are lost to follow-up must be tracked well in time, even at the stage of miss rather than before they become LFU. That was a brief about the WHO guidance on the key populations. Very quickly, I will just focus in 2 minutes on vulnerable populations, particularly the prisons and closed settings. ART initiation in closed setting is challenging due to operational issues, limited availability of security personnel and vehicles to take PLHIV to ART centers. So it is desired that services should be provided to under-trial prisoners within the confines of the prisons as far as possible, so that they don't have to be taken to ART sites. And in this, there are 3 situations: people who are not on ART, but in prisons who are already on ART, and their follow-up. So the situation has to be basically individualized depending on country context, but the medical officer of the prison, all medical prisons have medical officers, they should be adequately trained for ART initiation using rapid ART algorithm and concurrent sample collection, not waiting for the sample collection. We know CD4 count is not required for initiation of ART. Those who are already on ART should be provided basically all ART services, including counseling, refills within the prisons with a linkage to ART center, so that when the persons are released, there should be a clear post-release linkage plan. Then the prisoners, when they're released, of course, they may not like to give their the contact where they're going to, but their effort should be made that they should be registered to the nearest ART center and then transferred out to the nodal center in their own locality. Similarly, for the migrant and mobile population, it is very important that we should identify PLHIV who have got a potential for migration, whose families or peers have gone to the other destination. So we identify them, get their contact details, provide them details about multiple dispensing, transfer out mechanisms, and then once they reach the site, the follow-up should be done by the site so that they are retained in care. So to summarize, ART we know is a lifelong therapy. We don't require CD4 count. The person has to be monitored with a 6 months viral load, which has been adopted by all countries. But I would like to say that initial preparedness counseling is very essential before beginning ART. While we make effort for early, rapid, same-day initiation, we should not lose the focus on preparedness counseling. And differentiated model of service delivery need to be adopted for key population to increase access to ART and retention in care. Thank you very much for this opportunity.
Thank you so much, Dr. Rawari. I do apologize to rush you from your presentations, but that was so comprehensive. We're just running a little bit out of time. I'm just wondering if anyone's got any questions that they'd like to raise their hands to ask either Dr. Rawari or Davi. Anyone with their hands up? No. Dr. Rawari, there is a question for you in the Q&A box about the weight gain in TLD use might lead to intersection related to other chronic diseases such as diabetes and other cardiometabolic diseases. Any tips on how to mitigate that?
Basically, I said basically on the in terms of cardiometabolic diseases and cardiovascular diseases, the issue with dolutegravir is basically on weight gain. So it is very important that we provide adequate counseling for a healthy lifestyle, healthy nutrition, exercise, and of course regular checkup for blood sugar, HbA1c, and also the lipid profile. These are the recommendations that have come in basically with but the incidence of diabetes or newly onset diabetes is not significantly high. That is one part. Secondly, we know that with dolutegravir, there are some issues with the derangement of the liver functions, which may basically be a concern, but any increase of liver functions beyond 3 to 5 times, beyond 5 times is only significant. I hope I got your question correct, or it was related to hepatitis co-infection. When we talk about co-infection, we know that hepatitis C co-infection and the drugs for hepatitis C are easily available now. I will not say access is great, but the costs have come down. So we should actually make access, particularly for key populations. We really need to bring hepatitis C access and cost of reduction so that they can be provided. And we know that these are the drugs which have got a potential for cure. No other infectious diseases of chronic infections has got a cure. So we really need to work with countries on increasing access to that.
Thank you, Dr. Rewari. Can I just bring Davi back and just see whether you have any reflections after the presentation from Dr. Rewari? Davi. Where's he gone? Oh, no problem. Can I just ask our team to put out the links to the Jamboard? So, we want to make sure that this is an interactive session. So we've got 2 questions that we'd like to ask you in terms of this particular session. For you to write in your country name on the Jamboard sticker. So country level challenges, and then one for recommendations on ART access. Thank you, Nikki. So Nikki has already sent in the link onto the chat box. So please follow that link. So you will get to 2 Jamboards. So one, you have to write in the country name and then the challenges. And then the other one, your country name and the recommendations. So we are looking at challenges and recommendations from your country level. Is that good? Can I have a thumbs up if you're okay with that? Thumbs up? Great. And then we'll have time to look back into the Jamboard later today. Right, I can see now our next presenter for sharing the session on ART access gap in the Pacific, Renata Ram, the country director for UNAIDS Pacific based in Fiji. So we're looking at countries with a resurgence of HIV infections in the Pacific region. Thank you so much for joining us. Really late your time.
Thank you so much, Midnight, and to the team at APCOM for actually inviting me and including the Pacific in this very important webinar. And I've learned a lot. And great work to Davi, and thank you, Dr. Rewari, for your great session. Ooh, am I not sharing the correct screen?
No, that was not.
Yes. So, as Midnight said, I'm Renata Ram. I'm from UNAIDS. I'm the Pacific Country Director. The office here that's based in Suva in Fiji covers 14 Pacific Island countries. So before I can talk about our challenges here in the Pacific, I need to share with you about the Pacific. I mean, a lot of you may not know much about the Pacific region, and so I'm just going to give you a short lesson. Okay. So one of the issues here in the Pacific is that we do not have good internet, and I believe my slide is not sharing. So I would, if I can ask that my slide be shared from your end.
Sure, I'll have my team. Team, can you
Yes.
please share?
Sorry about this. Yeah.
No, it's okay. Yeah, I think
Yeah.
you made the point about the internet access.
Just a moment.
So while we're waiting, for those who are with us, can you name one Pacific Island country, if you can put it in the chat? Anyone? Fiji. Besides Fiji. Tonga, yeah, Samoa. PNG, yes. Your neighbor PNG, yeah. Okay. Thank you. All right, if I can have the first slide, please. So this is the Pacific region. As you can tell, it's a number of countries all located over a vast ocean. So there are over 25,000 islands divided into Melanesia, Micronesia, and Polynesia. And all these different regions have very different cultures and different economies, health systems, and resources. Economically, these countries rely on agriculture, tourism, and also marine resource extraction. There are many health challenges. This include limited access to healthcare, high rates of non-communicable diseases. As for development, many of these countries face common challenges, including limited transport, communication infrastructure, as we experience right now, vulnerability to climate change and natural disasters, and a significant distance from main markets, which often results in very high transportation costs. Despite these obstacles, there have been ongoing efforts for sustainable development, focusing on enhancing resilience and promoting inclusive and sustainable growth. So many of these countries are donor-driven or donor-dependent. So what happens is that most of the health programs as well are very reliant on these donor funds. So if a donor does not focus on, say, for example, HIV, then programming in these areas are really poor. We can go to the next slide. So the area that I highlighted is the area that I cover from the office here in Suva. And just to give you some context on the HIV funding landscape, is that over the past decade globally, there has been reduced focus on HIV. And this is largely due to competition between other countries with higher epidemics. So as I mentioned before, the region is very donor-driven and donor-dependent. And what has happened is that most programming has really fallen. And whilst the number in the Pacific remains comparatively low, the existence of high vulnerabilities is driving the increasing infections in the Pacific. So countries such as Fiji and Solomon Islands largely support HIV programs through domestic funds. And the other Pacific Island countries are covered by Global Fund. Unfortunately, the countries that I've highlighted are not covered by PEPFAR or USAID. If I can go to the next slide. So the HIV epidemic profile. The numbers are quite low, but it's because our population is quite low. So the Pacific Island countries have a key population-driven concentrated HIV epidemic. And it's mainly concentrated in men who have sex with men, sex workers, transgender women, and young people. The Pacific Island countries suffer a high burden of sexually transmitted infections. But the prevalence and incidence of STIs in individual countries over time are not well known. It is important to note that the Pacific has a very large uncontrolled STI epidemic. Under previous regional and HIV STI funding, there used to be a comprehensive control program. But however, in 2014, this had fallen away. So the Pacific generally is a low HIV prevalence country. However, data from the Pacific must be viewed with a lot of caution because testing is quite low, and most of the data is focused on women attending antenatal services and in populations accessing voluntary testing, and most of these are very opportunistic. So, and another thing that I want to talk about is the ART coverage. So as you can see, most of these countries with 100%, or the other countries besides Fiji, this was only achieved in 2018. And this intervention happened when there was a regional PL-HIV forum where all these people living with HIV were invited to Fiji to have a session with a peer HIV network that was running in Fiji to actually talk to these people living with HIV from the other Pacific Island countries, because in those countries, they do not have any such network or any peer support group. And as a result of that intervention, all those people living with HIV were convinced to go on ARV treatment, and ever since have been very good with their adherence to treatment. So this goes to show the importance of peer support and community-driven interventions. But unfortunately, till to date, from 2018, these other Pacific Island countries, I'm talking about Samoa, Micronesia, Kiribati, and the list that goes down from that, from what's being shown on the screen, still have not had people brave enough to become public and be an advocate in their countries. And most of the work that's done in this space is from Fiji. If I can have the next screen, please. So I want to focus on Fiji. So I don't know if you've noticed, but I've been really emphasizing on funding and donor priorities. So we can see that Fiji in Asia Pacific is the second fastest growing epidemic. And this has been a result of shifting donor priorities, the government losing focus on HIV programming, and a whole number of other issues. So Fiji has increased its estimated new HIV infections by 129% over the last decade, from 2010 to 2021. And this would change when we release our data, the next round of data this week. So this data will grow old, but for this presentation, I'll just use this for now. And the Global AIDS Monitoring Report shows that 173% increase of AIDS-related deaths in this period as well. And the rise of HIV infections in Fiji causes a threat to HIV in the Pacific. As from the map, you could see that Fiji is in the center of the map. It is considered the hub of the Pacific. It is a transit point for vast migration. An uncontrolled HIV epidemic and undetected transmission in Fiji can pose threats to the health security in the Pacific as people migrate to and from Fiji for work, holidays, and studies. And this is especially for those among the younger population who are at high risk group for new HIV infections throughout the Pacific. If I can have the next slide, please. The other problem is in the Pacific as well, the people on ART is quite low. From this graph, you can see in the treatment cascade, there's only 46% of people who are estimated to be living on HIV taking ARVs. And this is based on 2021 data, but in 2022, this number has actually dropped. There are more people that have been tested and less people who are on ARVs. I have the next slide, please. So the current treatment protocol, which is practiced throughout the Pacific, is treat all regardless of CD4 count, treat all regardless of age. We have the adoption of the WHO 2017 recommendation on rapid initiation of ART within 7 days of HIV diagnosis. Most countries in the Pacific are using DTG as their first line of treatment. Fiji will fully move into this towards the end of this year. Viral load monitoring is usually 6 months, then 12 months, and then yearly. Multi-month dispensing has been a common practice, and mainly because of the geographical spread of people. We only have a few places that actually dispense ARVs, and so those people living with HIV who are good with adhering to treatment are usually posted out their ARVs like in a 6-month lot. Newly diagnosed cases, in terms of monitoring, it's 2 weeks and then monthly. ARVs in every Pacific country is free of cost. I can go to the next slide. So what are our barriers? There are frequent ARV stockouts, accessibility issues. I mentioned that most of the services are very centralized. Even monitoring for viral load, there's always stockout of testing reagents. There's high loss to follow-up. And this is because of many causes. People prefer to use traditional medicine or because of religious beliefs. There's a low understanding of HIV. There's poor peer support or lack of active HIV networks and high stigma and discrimination. And this is mainly for Fiji. If I can go to the next slide. Some of the recommendations that we do pooled regional procurement with strengthened in-country stock management and supply chain, having decentralized ARV dispensing and monitoring, implementation of loss to follow-up mitigation strategies, and also increased donor support for community-led interventions. Currently, everything is facilitated by the governments of each country. Usually at the community level, it's more on advocacy or some level of prevention. However, there is a large need for communities to step up in this space of service delivery and also for peer support for people living with HIV. The testing uptake in most of the countries is very low. So even the reality of HIV cases is not a true picture with what we're reporting. if countries have high STI rates, the HIV numbers are not adding up, and detection even at a later stage is poor. So it is highly possible that people may pass away from AIDS-related deaths without knowing that they were diagnosed with HIV. So that is all I have to share for you today. And I hope that you have a little snapshot of the Pacific and all our challenges in terms of ARV access, retention, adherence, and the need for more community-driven interventions.
Thank you so much, Renata. A round of applause for Renata. Thank you for
Midnight.
highlighting, I guess, issues, challenges in the Pacific region. Anyone got any questions for Renata? Can you please raise your hand? Let me see if I can see anyone with hand up. I think some people might be wondering, like, how big is the office in the Pacific to tackle these issues, particularly around the resurgence of HIV in Fiji? And are you seeing now donors are now coming in to ensure that they can be maintained?
Unfortunately, Midnight, the donor response isn't very strong. What usually happens is that you have to have a large number of deaths to really have people wake up to the issue. And the other issue is that our civil society is not as loud as they should be. They haven't been well sustained. Many of the strong PL-HIV advocates are not in the space anymore. They have either left the country or they have chosen not to do this work because of other priorities that they have. And in terms of the office, I am the only one covering these 14 countries. Yeah.
Oh, wow, gosh.
And, the sad thing is that Australia will be eliminating HIV, right? They're coming close to elimination, but just the neighbors have a different story. And this is a story of inequalities. And how can we bridge that gap?
Oh, thanks, Renata, for being so candid about that, because I think these are some of the issues, particularly in countries that are transitioning out of eligibility, for Global Fund for PEPFAR. How do you maintain those community-led responses and ensure that community leadership, when funding is decreasing, is not going into the community, development, the organizational development, and ensuring that new leadership comes along, rather than just on the biomedical interventions only. I think that this might come up in the next session when we're talking about the community engagements. As I didn't see any other hands, so please do give another round of applause for Renata, who's in Fiji. Thank you so much. I know it's really late your time. As I said earlier, we'll definitely have to connect the communities in the Pacific to also the networks here in South and Southeast Asia region as well. Nikki has sent a reminder for people to not forget to put your challenges at country level and the recommendations at country level in the Jamboard. So please do help us identify some of the issues, because we don't have a lot of time for the Q&A. So this is a chance for you to also let us know what are some of the challenges and recommendations that you have from your community. Okay, now without further ado, let's go into the country examples, how community have been able to fill in the gap. So we have examples from the Philippines and Thailand on reaching the most vulnerable in a country setting, simplifying ART access by using HIV self-testing. So I'd like to welcome Dan Vic, the Head of Programs and Innovations from the Love Yourself based in Manila, the Philippines. Mabuhay.
Mabuhay Midnight, and thank you so much everyone for joining in this webinar. So I'll just be sharing my screen. Can everyone see my screen now?
Yes, we can.
Okay, thank you so much. So, as Midnight mentioned, I will be mentioning some of the examples that we have been doing that are mostly community-led initiatives, especially here in the Philippines. I think, as in the slides earlier, you have seen that the Philippines is experiencing a fast and furious epidemic in terms of HIV. That we are experiencing, we are diagnosing 50 cases per day. And I think this one example that we did in Love Yourself, a community-based organization based in the Philippines, has provided ways on how to engage to key populations and how they can be retained to ART, how they can access ART via our self-testing approach. So I think I should start first with a change in paradigm mindset. A change in paradigm meaning this dictates how we provide our services moving forward. What we have seen in our programs and our initiatives as we speak is that we tend to some sort of zero sort, or meaning, okay, for people who are living HIV negative, these are the things that you need to do. For HIV positive, these are the things that you need to do. We need to have a change in paradigm in order to destroy that zero sorting. We know that HIV is already a highly stigmatized disease and it's very prone to discrimination. So we want to change that mindset into introducing a status neutral approach, which has been introduced in multiple countries, especially in Thailand. We are employing this approach in our services that we are providing, especially when we offer testing, prevention services, and ART. What we are doing now is we also would want to espouse that not only on that paradigm, but in order for our community to access an HIV service, there are always practical and personal needs. Practical needs, these are mostly biomedical. When someone accesses an HIV-related service, they would want to know their status, they would want to enroll to PrEP, or they want to enroll to ART. So these are the biomedical needs that someone is accessing when they access a HIV service, and this only serves the practical need. But as I mentioned earlier, that HIV is a highly stigmatized disease, it has personal needs. These personal needs addresses the intersectionalities that are attached to the disease itself, attached to HIV in itself. And these personal needs addresses mostly psychosocial problems that are attached to the disease. And these directly affects the lives of our clients. So when they access an HIV service, sometimes they answer the question, how do I move on after knowing my HIV status, especially if it's positive? How do I move on after accessing the biomedical service that is attached to that personal need? So for example, if I am on PrEP, how do I maintain negative? If I am on ART, how do I if I am positive, how do I maintain myself on ART, and how do I live a happy and healthy life? And with all of these services that we access also, we also need to answer the question, how do I move on with my life with the biomedical service that I need, address the personal needs that has been addressed, and flourish in order to, to sustain myself, to help myself in, in maintaining combination prevention strategies. So these are the questions that we need to address before we employ our service delivery, improve our service delivery in offering ART and offering testing initiatives. So what we did first in Love Yourself is we revised our campaign strategies. Campaign in such a way to normalize HIV, have it status neutral, and also ensure a combination prevention approach. So the messaging now is what works for you. Regardless if you're HIV negative or HIV positive, there is an option that works for you. And there is a combination prevention option for you. Prevention to transmit HIV or prevention to acquire HIV. So these are the status neutral messages that we have been espousing that is critically important before we enhance our service delivery. So as we enhance our service delivery, we have offered self-testing service, which is the gateway for us to know your HIV status so that you could access the prevention message of the prevention option that you need. And we have enabled this through our self-care program. The self-care program is the first unassisted HIV self-testing service in the Philippines that has been proactively offering unassisted self-testing in the Philippines. As we speak, just this year, we have provided around 20,000 HIV self-tests in the country. This is offered entirely virtually via Facebook Messenger. We have decided Facebook Messenger because it is the mostly used social media platform here in the Philippines. In this service, we have provided assistance in an unassisted approach, meaning we have employed digital innovations in order to help our clients in risk assessment, the delivery of the kits, instructions on how to use the kit, and reporting the results. And if they are non-reactive, they will be automatically enrolled to PrEP by offering PrEP through also this mechanism as well. But if they are reactive to their self-test kits, what is important is that if they reported to us their result, immediately there would be a Love Yourself volunteer that would be helping their needs. And we provide the needs, the help that they need by providing coaching and motivational conversations. So we address first the personal need before we could address the practical need in terms of accessing treatment. Personal need meaning understanding reasons that may stop them from accessing antiretroviral treatment. And this is critically important because we want to understand those reasons and set goals within themselves so that they could this will not be the future barriers for them to access ART or to retain themselves to ART. Answering questions that they may have prior to starting ART or prior to linkage to care, and set the goal for them to be linked to confirmatory testing and same-day enrollment to ART. So what we have did in our services is that aside from the virtual approaches that we offer, we also improve our physical service delivery component. So we offered same-day ART, we offered once our clients get there, we are also a confirmatory testing facility. We provide same-day ART. We provide free CD4 and gene expert for tuberculosis immediately to them so that they will be enrolled to ART. So these mechanisms that we have improved in our physical centers so that it would be a seamless experience from the service that they got online to the service that they are getting once they have decided to be linked to confirmatory testing and linkage to care. So it's very important to understand that for us to enhance these messages, to enhance the services that we offer also, it is very important to enhance not only your virtual interventions, but also your physical interventions as well. So what I've been doing in this service is that we have trained our volunteers in order to provide motivational conversations, and these are done by peers. So these are done by community volunteers, and they're trained by coaching strategies from a module based from the Hudson Institute of Coaching in the United States. And we monitor our self-care accounts every time. We ensure that there are volunteers on standby, because there are some clients that are messaging us, reporting the results even during and after midnight. So, we need to employ differentiated service delivery options also for our clients so that we really cater to their needs. So this is what we did in order to simplify ART and also offer it through our self-testing approach. So with that, thank you very much for listening to our story. And we welcome if there are any questions that you may have.
Thank you so much, Danpik, and you did that within time as well. So if you have any questions, please also write that into the chat box. But I think I'll bring in the next speaker, and then we'll have some more questions as well afterwards too. So the next person, Kun Jamrong Pang Nong Yang, is the Deputy Director of Swing based in Thailand. He's going to be talking about reaching the most vulnerable in Thailand, looking at community-based ART services for sex workers.
Okay, can you see my slide?
Nope.
Hello?
Hello. No, we can't see your slide. You have to share your screen. Hello, or maybe APCOM team has the slides and we can share from our end as well.
So can you hear me, Midnight?
Yes.
Oh, I'm sorry, but something wrong with my internet. Even you ask me to check, but when I check, it's okay. But when I want to use it like that. Okay.
Oh, we can
Can you
see
see
it
my
now.
slide?
Yes, we can. Yes.
Okay.
You just need to put this into slide mode.
Full screen. Okay. Thank you, Midnight, for your and APCOM, and I have to say good afternoon, everyone. สวัสดีนะคะ So today I just on behalf of the community people, we want to show you that something that we try to solve the problem or to fill the gap of ARV service in Thailand. And so today I just want to show you about the community-based same-day ART that we can provide service in our community base. So this is maybe I just step back for the Thailand. Why we have an idea to start. Can I turn off my camera? Okay, sorry. Because why we have an idea to start same-day ART in the community-based organization, because we have a limit of access to ARV service in the past. That ARV clinic in the hospital is they take a long time to get a same-day ART, and some hospital they have service for same-day ART service only 2 days a week. This is sometimes it mean if I got my result today, but if they are provide only Monday and Thursday, if I have to waiting something like that, so I sometimes we have a little bit of, not a little bit, we have a lot of people who are lot to access to ARV, and also the some in Thailand we have the law that if you want to if you are the positive and you under the UC, you have to go to your the province that you was born, because you are right to access to treatment in the area that you was born. If you are non-UC, if you are working in the company or working in the another province, and you register your right to access to treatment in the hospital that you are registered. So what this is the a little bit limitation for us to access to ARV, and why that limitation is make our low adherence for clients who are get SRV also, because if you need long term to access to same-day ARTs, mean you have to if some limitation to access to ARV is make you low adherence also. Okay, and what's wrong with my slide? Can you see my slide? It's still the same page?
It's still the same page.
Oh my God, all right. Okay. When we want to start when we want to start the same-day ART project, so sorry. Okay, we have some we have to working on advocacy to work with with the hospital, because they are always thinking that they are not how to say, they are not trust in the CVO service to get because now we can trading by the community clinic, but when we want to provide the ART, the government or the doctor or the nurse in the hospital, they didn't how to say, they not trust in our standard of the service for the community people, and they are still thinking about if the client who are positive and the doctor cannot consult or cannot see the client. They are concerned about how the community people can consult and know the status of the OI or something like that. This is also the thing that the government they are concerned. And this is why we have something that when we talking with the government, they didn't like the previous slide. They are not taught in community-based clinic, but they are still we still good very good relationship with the hospital. And after that, we are thinking about the pilot project to show them the data to show the data that community-based organization can provide ARV service for the case who are HIV positive also. This is very good that we are very close with the ISI to do the to who are the technical support for community-based organization to provide the clinical service. And also we expand to technical support from ISI to do the same day RT also. And we hope that in the future we can show our study to our the successful of our study to show the government that we can provide the support or the provide service for same day RT with the community-based organization. This is the thing that we working on this with the ISI. Also, this is include a criteria for the pilot project. I think I don't want to get into the detail. Just when we want to start the pilot project, we have to set up set the criteria for the people who want to get same day ART also. And this is the performance that we are working with ISI during the April 2024 until May 2023. But this is the number of the people who are tested and HIV positive, about 467 cases, and but who are can access to same day ART only 266, because some of them they are the criteria that we set up under the UC healthcare. But if you are the security ประกันสังคมอะไรนะพี่พิษไหน social security, right?
Yes.
If you're under the social security, you cannot you cannot get the same day RT. So why the number of people they are half and half who are under UC and not under UC something. So but four of them when we consult them, we have some sign of the TB or something like that, so we refer them to do the chest X-ray. But four of them they are that, but we can now they are can refer to ARV treatment already. But for the number, I back to the number for 637 who are not 200 of them they cannot access not the same day ART, but now most of them is already get ARTs already. Just only 6 of them cannot access for now, but we can still connect to them. So when we have the data like the previous slide, after that we try to convince to show the data with the government hospital. We start with same day ART. We start the program same day ART with the Bang Lamung Hospital in Pattaya, because this is the doctor who are the director of the Bang Lamung Hospital. He is very supportive, very agree to start same day ART with swing. We are start our same day ART program in Pattaya on Valentine's Day. And this is for the bank in Bangkok. We just only start on only one month on 6th of June. We this is the government they came to see swing to do the service for as swing, to see the service for as swing, and they decide to start same-day ART just only 1 month. This is also the include criteria similar with the when we started pilot project. I didn't go into the detail. This is a service flow. Is the same with the flow in our clinic, but if you are HIV positive and you need to you decide do you sign the consent form to join the same-day ART, we have to get more like a CD4, we have to testing a CD4 or something like that for them, and after when they get the result, and we take 1 hour for the result. When they get the result, we can consult with them post counseling for 15 minutes, and after that they have to sign the consent form to join the same-day ART, and they can get ARV and go back home. This is the benefit, I think, for the same-day ART that can benefit from even our client, benefit for swing, and benefit for the government hospital also, because we can reducing the burden for the hospital also, and we can follow up the client, taking client to the hospital. We can how to say give them the consulting, even they are not only the physical, when we consult in mental health also for the client, and everything is free of charge. This is the benefit for this program. This is the performance for swing in Bang Hospital. Bang Hospital, even we start same-day ART program together, but in Pattaya we have Thai people who are positive, 66 of them who are the Thai people in 4 months, and only 9 of them who can access to same-day ART, because in Bangladesh Hospital they are service for ARV only 2 days a week. So what it means, they are provided on Monday and Thursday. It means that if the client got positive result that day, they can access to same-day ART. But if they are positive on Wednesday, on Saturday, or on Friday, something like that, they cannot access same-day ART. They have to waiting until Monday and Thursday, something they can get access to the but this is also in Thai people. 50% of this they are non-UC. So by some of them they are non-UC. This is for the BMA. BMA only 1 month.
Can you please wrap up? Yeah.
Okay. It's over time, right? Time out. Okay, this is the case from Bangkok that 35 of them they are positive, but nearly 50% they are 12 of them they can access to same-day ART. This is I just want to summarize the timeline that the first we saw the limitation of access to ARV, and we do the pilot project, and we show the performance to convince the government hospital to start do the program, same-day ART program. And this is the just after that, just last on 20th of June, the government hospital from Bangkok and Pattaya, they are do the exchange learning between the government and swing join them, because we are working together like a partner. Thank you, Ka.
Thank you, ขอบคุณครับ. Can I just bring a round of applause for Pitti, and then can I bring Dan Big back as well? Just want to ask you one question each. I know we're running out of time, and if it's okay, we might be about 10-15 minutes over the time. I hope that's okay with everyone. Yeah, Dan Big and Pitti, you know, you like community-led responses to the communities in your level. It sounds so wonderful. I have to say, I think a lot of people online probably wondering, like, if they were to do the same thing in their own settings, what would be your recommendations from a community point of view? Danvik.
I think one comment that I can say is that here in the Philippines, when we always do community-led approaches, communities are not just included in the response. They are the architect of the response, meaning we are involved in decision-making. We are involved in designing the service in itself. So it's not just task sharing or task shifting. It's listening to the communities, what they want, listening how we will implement the service and how we will basically make it sustainable. So as I always say in my presentations, I always say that we know the market because we are the market. We can always design the interventions that we want because we ourselves, we would want to have that service in itself. So I think community involvement doesn't necessarily mean you just involve them in the conversation. It's making them sure that you trust them to be the architects of your future service delivery. I think that's one recommendation that I can highlight.
Wonderful. Piti, any recommendations for the other community organizations in other countries?
Yeah, I think for recommendation, we just make a partnership with the government to work together, but make equal partnership, not someone over, someone under, something like that. So I think the partnership is very important, and we should be the owner of the community, even you are the government or you are the community people. I think this is quite important for work together.
Oh, thank you. Those are very powerful recommendations. I just drop us right into our last speaker, Kun Ampika Purvanasathian, who is the Senior Technical Officer, Care and Treatment of USAID APIC Thailand, based in APCOM 360. The role of the community-led monitoring in improving the quality of ART access.
Thank you, Kun Midnight. My name is Ampika Purvanasathian. Let me share my screen. Can you see my screen?
Yes, you just need to put that into presentation mode.
Okay. Okay. Good afternoon, everyone. My name is Ampika. I'm a Senior Technical Officer, Care and Treatment Team, APIC Thailand. Today, I would like to share with you about the role of community-led monitoring in improving the quality of ART access. I know that the last session talked about the community-led, but my session talked about the community-led monitoring is the concept. Today, I will talk about the concept of community-led monitoring and the current CLM activity under APIC Thailand and the improvement of the quality service by using the CLM data. So the community-led monitoring CLM is the mechanism for HIV response led and implemented by local community organization of PEPFAR and their network to monitor the quality of service. The CLM data provide the evidence what works, what is not working, and what should be improved through the service, through the client satisfaction and feedback. So with partial support from Care and Treatment Team APIC Thailand, USAID, we start this activity in 2022 in two provinces, Chiang Mai and Chonburi, with one pilot hospital in each area. In the beginning, we coordinate with the provincial health officer, provincial health office to present the CLM concept and allow CLM activity to be carried out in the province and invite the key provincial CBO to join the committee. After doing activity in the first year, the hospital staff and provincial network and key population saw the benefit because the client received better quality of service. So they continue this activity this year by expanding the implementing hospital and inviting the other CBO to join the community in Chiang Mai and Chonburi province. And also this year, we expand to the Songkhla province. Also, this year, the community in East Province has been formally established by PHO to carry out the activity independently with sustainability under support by PHO and Office of Disease Prevention and Control and hospital in the province, and CLM leader was selected by community member. So yeah, the role of CLM committee include implement the CLM activity in the province and coordinate with academic organization and provincial network to support the CLM activity, and represent civil society in public relations and lead the community to drive the policy implement if needed and manage the budget. The activity of CLM include define the activity of CLM committee, including define the CLM activity and timeline, and hold a meeting with committee and stakeholder in the province to clarify the objective, responsibility, step of work, and timeline of CLM activity, and develop the CLM questionnaire, conduct the data collection and analysis, and discuss the result and improvement plan with healthcare facility in the province. So for the data collection, the committee discussed with academic organization in province to create the online assessment platform to collect the data. You can see your left side is the online platform for client to complete the survey. This one is generated by CLM committee in Chiang Mai, and also discuss with academic organization on the data analysis and the presentation. Before they conducting the online data collection, the committee will train their network, PLHIV network in the province to have the same standard in conducting survey. And they collect the data from all population, includes MSM, TG, sex worker, PWIT, male, female, and the questionnaire assess 4 topics based on the HIV flow, including prevention, treatment, stigma and discrimination, and management issue. And then the CLM committee, after they analyze the data, the CLM committee hold a meeting to share the results with healthcare facility and stakeholder, and discuss the improvement plan to respond to the client's feedback. These pictures show how the provincial CLM committee works. And this is the results and improvement, the CLM finding and improvement in year 2022. I will highlight some improvement such as improvement of ART service in Chonburi. The finding is long duration ART refill service. But the hospital and director, the hospital staff discussed the improvement of this service, and they agree to scale up the DSD of ART service to ensure the continuity of treatment. This includes the ART telehealth, mailing service, and after-hour clinic, and set up the roll-up to promote DSD in front of the ARV clinic, so the client know and request DSD service, and develop the queue system to facilitate the refill. These activities reduce the waiting time for ART refills and facilitate the patient to receive their planned medication. And for the other evidence of the benefit of implementing CLM, that include the community is implement to monitor and improve their service by themselves rather than the top-down approach. So they are more effective work. And the second one is they have the good collaboration between community healthcare provider to solve the problem together. And the last one is advocacy by the community-based organization, sustain improvement in access to anti-HIV service flow. That's all from my presentation. That's all from I would like to share with you about the CLM activity to improve the quality of service.
Thank you so much, Khun Ampika. Anyone got any questions for this presentation on the CLM in Thailand? Maybe I'll just add one quick question. Khun Ampika, in terms of sustainability, has that been discussed for the CLM in Thailand, and how are they looking to sustain this community-led monitoring? So you're on mute. You have to unmute yourself.
Sorry. Can you hear my voice?
Yes, we can now.
So we established the CLM provincial, we call in terms of provincial CLM committee in each province to work in CLM activity and sustain that work in each province by and support by PHO. So the next year the committee can lead this activity by themselves.
Thank you so much, and I want to thank all of our participants who are staying on after the the 1/2 mark. If you don't mind, can you please put your video on so we can see you on screen and we can do a group photo. I want to say thank you on behalf of the team in APCOM, and thank you also to the PEPFAR USAID EPIC for the collaboration for this really important webinar on ART access for the region, particularly for the key populations. Of course, I want to say thank you for the partnership and also leadership of Davi, who is a young PLHIV officer of Asia Pacific Network of People Living with HIV, Dr. Rewari from the WHO Southeast Asia Regional Office, Renataram, Country Director of UNAIDS Pacific. They have to go, so they're not here with us. Thank you, Danvik, and also thank you, Piti Kunjamrong from our community organizations to really inspire us to really take that leadership role. Thank you so much, Ampika, in terms of the presentation on the CLM, how that's been working in Thailand. Okay, if you're all comfortable in your having your your face on the screen, our team can count down and then we can do a screenshot. We cannot hear you. So look at the camera.
One, two, three.
Maybe one more. I think some people might blink, right? Mm-hmm. Okay.
1, 2, 3.
Thank you so much for Dr. Spanes, who is just doing our technical work. Thank you so much to Nikki, who's also been coordinating with all our speakers for this session. Thank you so much to Selvan, who's also started to help with the coordination and also taking notes. You will be given the notes and also the videos and also the presentations. But there will be a short survey that you need to help fill in to ensure that we can improve on our webinars in the next one. Thank you so much. And and also one more thing, you can also receive a newsletter as well. So they will be part of a newsletter. So if you go on to apcom.org and then sign up on there, you'll also be able to receive from that channel too. Thank you so much, everybody. And on behalf of APCOM, ขอบคุณ and สวัสดีครับ